Bueno, bienvenidos a todos a una edición más de los Coloquios IB. Hoy tenemos una invitada especial, así que la va a presentar Inés Zamengo, así que te dejo toda la palabra a vos, Inés.
Okay, so it's a big pleasure for me to introduce you to Magdalena, who is originally from the Czech Republic, and where she took her undergraduate studies, and then she continued her career in the US, first in her PhD in McGill University, and then her postdoc training at Stanford, right? And she's presently, I'm going to read this, an associate professor and Tier 2 chair in medical physics in the Department of Physics and Astronomy in the University of Victoria, British Columbia, Canada. So Magdalena just is spending here 2 months of her sabbatical year, which was very lucky for us. She just wrote to us and said, I'd be delighted to spend some time there in Bariloche, which for us, the Department of Medical Physics, was great. So we are very happy to welcome her here. And the topics that she works in are Monte Carlo simulations, also experiments in X-ray fluorescence and tomography, small animal radiotherapy, flash radiotherapy. And she got the 2018 Laughlin Young Scientist Award, and she's a deputy editor in the Journal of Medical Physics, in medical physics actually. And today she's talking about radiation therapy. Is expensive and sometimes not accessible, so I guess the point of the talk is to see how to better organize resources to be able to help more patients. And I'll leave you, yes, with the audience.
Okay, thank you, Inés, for the introduction, and thank you, everybody, for coming. I would really like to give this talk in Spanish, but you would not like that, I can assure you. Pero quisiera decir unas palabras en castellano y quiero decir que Bariloche es una ciudad muy, muy linda con las montañas y el lago y que la gente en el instituto es muy agradable. Pues muchas gracias especialmente a Inés y a Mauricio por dejarme trabajar con ustedes durante 2 meses. Muchas gracias. And this is it for Spanish for me. So today I'll talk about a project that we have been working on for more than 10 years right now. And it's really how we can make radiation therapy more accessible. And it's a little expensive, sometimes very expensive. And this project comes from a radiation oncologist, Michael Weil, that I'll talk about a little bit, or at least have him on the final acknowledgement slide. And he's a radiation oncologist, a physician, who was practicing in California after I don't know how many years of radiation oncology training, and he realized that radiation therapy is indeed very expensive, and he figured out that he wanted to make it a little cheaper. So he quit practicing. So imagine, not having salary of $300,000 a year, and he dedicated his time to coming up with an idea and materializing the idea of decreasing the cost of radiation therapy. He did that for a few years, then he realized he actually does need money, and he started practicing again part-time, so that's what he's doing right now, but he's still dedicating quite a bit of his time to the development of a cost-effective radiation therapy machine. Okay, this is my disclaimer. I was involved with Precision RT and Serious Medicine, who partially funded this work, and I also have a consulting agreement with a different company. So first of all, I'd like to say that my amazing students did all this work. So these are 3 of them, Dylan Brightcourt, Jericho O'Connell, and Henry Baxter. And without the contribution of my students, nothing would ever get done, at least not from my side. So I think it's important to acknowledge them. So how about cancer? It is the leading cause of death worldwide, and in 2020 it accounted for 20 million deaths, which is 1 out of every 6 deaths worldwide. I actually looked up the statistics for Argentina. It is not the leading cause of death in Argentina. It seems like it's cardiac disease, which is interesting. And this is the same for the US, but for Canada, where I work right now, it is actually cancer. So So let's look at cancer worldwide, a little bit at least. So this is cancer incidence. This is not cancer deaths. And I'm sorry for the legend that you cannot really see very well. Neither can I, but I memorized some stuff. So in panel A, we see data for men, and in panel B, it's data for women. And this is basically just showing us what are the most frequent cancer diagnoses. And you can see half of the world, really, or maybe 3/4 of the world are green, which is the diagnosis of prostate cancer in men. So if you live, unfortunately, guys, if you live long enough, you will be likely diagnosed with cancer, with prostate cancer. And the probability is, I think, 80% at 80 years old or something like that. But that doesn't mean that you will die of prostate cancer, thankfully. And you see that a big part of Asia, for the big part of Asia, the most common diagnosis is lung cancer. And that's probably due to smoking. For women, on the other hand, you see that most of the world is pink, and that means that breast cancer is the most likely cancer diagnosis in most countries in the world. So this was cancer incidence. How about cancer deaths? And you see the map now looks very different. Again, men on top and women at the bottom. And for men, we see that men, when they die of cancer, they will die of lung cancer. So treatments of lung cancer are very important, and that's really partly what our project focuses on. But note that most prevalent cancer is prostate cancer in men, but men die mostly of lung cancer. In terms of women, you see that actually lung cancer is the main cause of death for women cancer patients in Canada and the US, in Australia and China. But for the rest of the world, it is still breast cancer. So breast cancer is also an important aspect or an important cancer site to be focusing on, and that's also the case for our project. Okay, so for cancer treatments, I'm sure you know of the three main. Do you have questions?
Can I interrupt?
Absolutely, yes.
The fact that, for example, in some regions of the world, although the prevalence is greater for breast cancer, for example, but you don't die from
Breast cancer?
breast cancer, you die from some other cancer, is that because the cancer is more severe for particular ethnicities, or is it the treatment that?
I would say it can be due to a number of reasons. One of them, these cancers might not be as deadly, for one. You can live with them. They might be slow growing. Right, but in terms of, I don't think race might play some role, but not such an important role to be flipping this data as much. So it's basically maybe earlier diagnosis, better treatments, or treatment availability to start with. Okay, if there are any questions, just let me know. I'll try to make sure that I'm looking at you and catch the questions. Okay, so in terms of cancer treatment, what I was saying, that there's three main types of treatments. There's more, but the three main still are surgery, chemotherapy, and radiation therapy. So in terms of surgery, it is the oldest type of treatment. You basically take the tumor out in a surgical procedure. It works well on solid tumors, but of course, if the cancer has spread and metastasized, this is not gonna work anymore. For that, for example, chemotherapy is pretty decent. It started in the 1940s, and it's basically the delivery of drugs that kill quickly dividing cells. And that's one of the reasons why your hair falls out, patient's hair falls out during chemotherapy, because those are also quickly dividing cells. And of course, there are side effects, such as hair falling out, but this is not a very severe side effect, and it's typically delivered over multiple sessions. It can be delivered orally, actually, as well, but very often it's delivered through IV, as shown on the picture there. And the third main treatment for cancer is radiation therapy, and that's, of course, the treatment that I will be focusing on in this talk. And it's the first radiation therapy, at least with linear accelerators, was delivered in 1950s. It's the radiation that damages DNA and kills cancer cells. Unfortunately, it doesn't only kill cancer cells, it also kills healthy cells, and as a result, there's also side effects, and it's also delivered in multiple sessions most often. So sometimes patients go to the cancer center for 5 weeks to get treatments every day of these 5 weeks. So how does radiation therapy work? We need to know where the cancer is. For chemotherapy, we don't really care as much because it's systemic treatment. for radiation therapy, we're trying to pinpoint the cells, the cancer cells with radiation. So it's very important that we know where these cancer cells are. So for this purpose, we often, for radiation therapy, acquire CT images of the patient that give us the distribution of the organs, of the anatomy in that particular patient, and also we can see where the tumor is. So for example, this is an axial view of a patient. Of course, this is the lung of a patient, and I'm sure everybody here can see where the tumor is. So it's a very well-defined tumor. Of course, unfortunately, that's not always the case. So when we take CT images, we need to identify the tumor, and we need to basically segment all the organs of the body, because we understand how much damage we do to a certain organ if it receives a certain dose. So we delineate. I don't know if you can see the green contour around the body. That's typically done in an automated way. However, the delineation of the tumor is done by a physician. So a physician has to come in and they have to say where the tumor actually is. And there have been multiple studies that have shown that you have two physicians, and you give them a single tumor, a single patient. Sometimes there's no overlap with the tumor, which is, of course, horrible. So we have to do a little better, and machine learning or artificial intelligence might help us in that regard. So we delineate the tumor, but we also delineate an area around the tumor, such as shown over here, just to make sure that we don't miss anything. For example, if there is some micro disease around the tumor, we want to make sure that we kill all the cancer cells. We also account for the fact that when we treat the patient might hopefully actually will breathe. And during breathing, the tumor might be moving a little bit, or during the setup of the patient on the treatment couch, the position might not be exactly the same as it was during the CT imaging session. And then we also delineate the other organs at risk. I'm not sure this is not showing really well, but you can see there's the spinal cord, for example, which is probably the aorta, the esophagus. So you can see that what we are trying to do after it is to deliver radiation to the tumor, and that's what's shown here in the color map. What we want to do is to deliver high dose of radiation to the tumor so that we kill tumor cells and we basically kill the cancer and the patient is cancer-free. But at the same time, what we are trying to do is to deliver no radiation to healthy cells. Unfortunately, that's never possible. We will always have some radiation to healthy cells, but the goal is to basically minimize the radiation to healthy cells. And this is radiation therapy for you. What I'll be talking about a little bit today also is a quantification of a dose distribution. So this, of course, dose distribution would be shown in multiple slices, and we are now trying to evaluate this dose distribution, and that's not very straightforward. So what we do, we take the dose distribution, the doses of the patient, and even though it's in 3D, we now combine it on a 1D axis. So this is shown over here. So we have dose in percent of the maximum dose, or it would be the red hot dot over here. And we look at the percentage of volume, or the volume percentage of an organ, and calculate what the dose to the organ is. And we express it in the so-called cumulative dose volume histograms, or DVHs, and those are basically just called DVHs. We don't talk about cumulative at all. So the ideal dose volume histogram for the tumor would look like this. And that means that 100% of the target is receiving 100% of the dose. And that's what we want. And no percentage of the target is receiving less dose than 100%. So this would be great. As a result, for example, an organ at risk, which might be the lung here, we would like to have something like that. We would like 100% of the lung volume to be receiving 0 dose. Unfortunately, this is not feasible. So if we look at the real dose distribution, the PTV, or the tumor dose, will look something like this. So there'll be, if you look at this point, for example, there'll be maybe 98% of the volume that will be receiving less than 100% of the dose. And for lung, we also won't get that. We'll get something like this. So basically, the goal of treatment planning, or the dose distribution, is to make sure that this point is as close to the top right corner as possible, and the DVH of the organs at risk, such as lung in this case, is as close to this corner as possible. And that would make for a good treatment plan. So there's a number of radiation therapy types, external and internal radiation therapy. External means that the radiation is delivered from the outside of the human body. Internal means that it's more invasive and it's delivered from the inside of the patient. So for external radiation therapy, we have photons delivered with linear accelerators. We've got electrons. They are more useful for skin cancer or shallow lesions. And there's also proton radiation therapy. And I hear that you will be getting, or you are getting, or the proton therapy center has been built, but it's not operational in Argentina. This is, of course, the most expensive type of radiation therapy. It's probably very good for pediatric patients. For the rest of the patient, it's not quite clear what the benefits are. I think there's some studies now that were not supported by companies who manufacture these devices that actually show that it might be better for some cases, but it's not absolutely clear that protons are better than photons. Definitely not in all cases. And so you know, in Canada, we don't have any proton centers. We used to have one, but it shut down. And there's also internal radiation therapy, which I will not focus on, but just for completeness, we can have what is called brachytherapy for these two cases that can be delivered at low dose rate. And it's basically these tiny seeds. They're about 3 or 4 millimeters in length and about 1 millimeter in diameter. And they're basically inserted into the tumor. So this is a pretty common treatment for prostate cancer. So basically physician loads needles with these seeds, can be 60 seeds, and they implant them into the patient's prostate. Of course, this is a surgical procedure. It's done under anesthesia. It takes some time. And these seeds actually stay in the patient forever. They can wander around sometimes, so it's possible that the patient pees a seed out, or it can actually sometimes be apparently found in the heart. But most often they just stay in the prostate. And as the radioactive source, I forgot to mention, important part, there's a radioactive source in the seed that has typically low photon energies. As these sources decay, they deliver radiation in the vicinity of the seeds. That's why you need many of them. And they kill cancer cells. There's also high-dose rate brachytherapy. And this is typically delivered with iridium-192, although I just learned yesterday that here you guys are using cobalt-125. Cobalt-60 with 1.25 MeV energy. And this is a high dose rate source, so it has to be stored in what we call an afterloader, which has a lot of shielding. And this is not manually inserted. It's basically the treatment is prepared, and then this afterloader manually inserts these seeds into catheters, into cables, into catheters. And the treatment time, well, this is basically left in the patient for the rest of their life. The treatment time here is probably a couple of minutes only. So different treatments. And there's also radiopharmaceuticals that can be injected into patients. And this is a very new treatment modality, and there's a lot of work that needs to be done for it as well. Okay, so now that we know there is external and internal radiation therapy, let's talk about external beam radiation therapy. And as I mentioned, that can be done with a number of particles, but let's talk about linear accelerators. So this is a very true beam linac. Here you have Electa linacs that are very similar. And radiation therapy is delivered in fractions to avoid normal tissue toxicity. Again, we don't treat the patient to the dose that I showed on the previous slide in a single session. We deliver it in multiple sessions, and that basically prevents normal tissues from getting as damaged as tumor does. Typically, we deliver them with 6 to 10 MV photon beams, so that's going to be important for my talk. But unfortunately, these linear accelerators are pretty expensive. They can be anywhere from $1 million to $5 million. And that's just the machine. Now you actually have to build a certain infrastructure around them. So you cannot put a linac, you can put a linac into this room, but if you were treating somebody who's walking outside, would be getting a little bit of treatment as well, and we don't want that. So we have to build really thick walls, and these are typically 2 meters thick. And so the infrastructure around linear accelerators is also expensive. In the US, I think what I've overheard a few times, treatments are expensive. So patients have to pay $50,000 for a course of treatment. That's the entire treatment. So of course, not everybody can afford it. Not everybody has insurance. And as a result, not everybody can access care. And this is really the motivation of my collaborator, Michael Weil, to see if we can make radiation therapy a little cheaper. And so why is also that if you look at the map, that basically shows us how many linear accelerators there are in the world per the number of patients that need treatment. And I know this is a really tricky map, but let's look at this 8-hour shift. So this is just difference in how long people are running linear accelerators. So let's assume we are running an 8-hour shift. And for example, here in Argentina, it seems like, I'm not clear which one it is, but let's say about 70% of cancer patients that need radiation therapy or that would benefit from radiation therapy can access radiation therapy. If you look at the US, of course, you get about 150% of patients who need radiation therapy can access radiation therapy. But you can see in Africa, there's lots of countries that have zero radiation therapy access. And that's partly because this is, it's so expensive to bring a machine in and operate it. The other issue that I'm not going to be talking about is, for example, the power grid in Africa. It's also not very reliable, so this is something that people need to take into account, as well as when something happens with these machines, if these institutions don't have contract with the manufacturer, their linear accelerators might be down for months, and patients therefore will be not getting treatment, or they might be halfway through their treatment and they will never complete it, or complete it too late. Okay, the map actually shows that 90% of cancer patients in low and middle income countries lack access to radiation therapy, and we would like to improve this. Okay, so how we are trying to do this, we are basically trying to decrease the beam energy from 6 MV to lower energies and deliver the radiation in a much more smart way, and I'll talk about it a little bit, which will then decrease the cost of the machine because we will not need these big linear accelerators, as well as decrease the cost for the infrastructure because, of course, with lower energies, you will not be needing 2 meters of concrete anymore. So let's look at a scenario in which we have a target at a 10 centimeter depth, and we are treating the target with 6 MV or 15 MV photon beams. So this is how the depth dose looks like. So this is the amount of energy that's deposited as a function of depth in patient, but you'll see that even though there is some dose in the target, there is more dose around 2 centimeters, 2 to 5 centimeters depth. So in order to get rid of this dose maximum in front of the target, what we do, we basically rotate the beam around the patient, around the target, and this way we actually create a high dose in the center of the target and basically just focusing the beam. This is what happens, and we get a nice dose distribution. Now, what happens if you look at low energy beam, so 100 kilovolts, now we talked about 15 megavolts, now we are down to 100 kilovolts. This is the dose distribution that we are getting, and you'll see that there's not very much in the target. Even if we rotate a single beam, this is what we'll get, and of course, the only thing that we will be doing in this treatment is just to burn the skin of the patient, and no radiation will be delivered into the target. So how are we going to do this? Well, it turns out that a group at UC Davis have looked at an X-ray tube, so they looked at a much higher tube voltage, so 320 kilovolts as opposed to 100 that I was showing over here. They also filtered the beam, so the more material you put in the beam path, the harder or the higher the beam energy will become and will penetrate deeper in tissue. This is a small phantom. I think they looked at breast treatments, but you can see that you actually can pinpoint very nicely with dose, 2 spheres in this case, and a line over here, or even like an O-shaped target. But this was a small target, I believe, maybe even 5 centimeters in diameter or something like that. But basically, this is a little bit of an idea that we had, but we improved it a little more. And as I said, if you can treat with X-ray tubes, you don't need these linear accelerators that are expensive. You don't need 2 meters of concrete, and you can save money. And this is what we are trying to achieve. So how exactly did we do that? We kind of took inspiration in this scanning beam digital X-ray source, which is just an X-ray source, which is a 2D X-ray source. It's got an electron beam. I think the highest energy that they could achieve in the system, it actually was or is a real system, was 120 kVp. And they had a magnet here that could steer the beam into a 2D array. Okay, so they could do this. It's shown over here. This was basically designed for inverse geometry X-ray scanning. So it's shown over here. So you have a large target and a small detector. Typically, we have it the other way around. So we looked at this. We modeled this with Monte Carlo simulations and modified the target slightly for radiation therapy. And so this is our idea for the target design. So we have an electron beam, again, that's scanned in a linear pattern. So instead of doing 2D scanning, we're just doing 1D scanning. We collimate the beam, similarly what's done in the X-ray source. We collimate the beam, but again, you'll basically get a line of X-ray beams on this other side. You have this, your linear X-ray source, and you deliver arc therapy. So basically, you're distributing the beam across a large volume of the patient. And the goal is to deliver a high dose to the target and low dose to the skin, and because skin is typically the biggest problem with kilovoltage radiation therapy. So this is the way to demonstrate this a little bit. So this is just a single beamlet. The target is at 10 centimeters depth, 4 centimeters in diameter. Sorry for the color choice. It's shown in black. And again, you see that for one beamlet, like we saw before, the highest dose is delivered on the skin and basically no dose in the target. Now, if we look at 9 beamlets, so this for this linear source, you see that there is finally some dose in the target, but still not very much. When we are looking at a 120-degree arc, so this linear source moves in a 120-degree arc, you're getting actually this finally at least the same dose in the target as you're getting on the skin, but of course this is still not very good. While you're treating the target, you're also treating the skin. But if you're looking at the different beamlet width, and basically you're redesigning this collimator, you're now getting the most dose in the target and not as much dose on the skin. So this is sort of the idea. We had to perform a pretty extensive parameter simulation study to figure out what is the best parameter setting to deliver the best dose to the target while sparing the skin. So this is just the collimator design. We looked at a number of parameters such as beam energy, target thickness. This is a transmission target. Number of sources, source extent, etc. And the goal for us to make this clinically feasible was to be able to maximize the output. So we wanted to be able to deliver 18 gray to the patient in 30 minutes. Of course, if you put a lot of filtration in the beam, you'll get higher beams, higher energy beams, but the output will decrease. And we cannot have patients on the table for 20 hours, right? That's just not feasible. So the requirement of Michael was to deliver 18 gray in 30 minutes. And he also wanted to achieve the target to skin dose ratio higher than 5. So 20% on the skin, 100% in the target. So this was our goal. So for this parameter study that we ran, it was lots of simulations that I'm showing very briefly over here. But we basically concluded that beam energy played a big role. So this is just D50, maximized D50, maximized target to skin ratio. In green, D50 in blue. We found out that the higher the beam energy, the better the target the beam output, and the higher the target to skin ratio. So that wasn't surprising, right? If you go all the way to 6 MB or 15 MB, this is going to be even better, but would have to use a different technology. So we knew we wanted to maximize that, but of course it comes at the cost of increased shielding. The skin to surface distance, how far is the source from the patient, had the best performance as well, so we wanted to minimize the source to skin distance. But this is also tricky because you cannot really go too close to the patient. In case the patient moves, shifts on one side, you might end up hitting the patient with the source, and of course this would be horrible. So that shouldn't happen. And the number of sources or the number of beamlet holes over here didn't actually matter. So that was kind of, just pinpointing some of the conclusions here. And so when we put all this together, we were able to get a dose distribution that looks like this. I know this might not look very exciting for you. Actually, it doesn't look as exciting for me anymore. But when I got this result, I was super excited because I never believed that with a kilovoltage beam, we can get a dose distribution that can look conformal just like this. So it was extremely exciting, and people still don't believe it even when we show them the data. So the target to skin ratio was finally 5.07. So that's what we wanted, of course, in this special case. And this was just done on phantoms. And the D50 was 24.2 gray and was supposed to be 18. So we are getting even higher output than we were asked. So it was exciting. However, this is just a dose distribution in a phantom. And unfortunately, humans don't tend to be cylindrical with spherical tumors. So we had to look at treatment planning, but we also started a collaboration with Imatrex. So Imatrex agreed to invest some money into this project and started building a prototype of the machine based on the design that we gave them. So patient dose distributions, we also use Monte Carlo simulations typically when you're looking at dose distributions in patients, you're actually using commercial software that comes from either Varian or Elekta. Of course, they have everything beautiful and everything works well. But it's only set up for the geometry of those linear accelerators. If you want to do something else, you have to basically build your own Monte Carlo, or you have to build your own treatment planning system, as well as do your own calculations, because kilovoltage dose calculations are very different than megavoltage dose calculations that are a little easier because of the different interaction types for the different energies. So we started a collaboration with McGill University, and we used their Radify, which is a treatment planning optimization system that they built for a different purpose at their institution. And so these are some of the first optimization plans, optimized plans that we have looked at. But again, do know that this is just for a spherical target. And since breast cancer is important, and lots of women die of breast cancer, in low and middle income countries especially, we have looked at a breast case. So on top, we have kilovoltage arc treatment. So this is our design versus VMAT. And VMAT is the high-end, top-of-the-line treatment planning and treatment delivery technique. So every time I'll be comparing our dose distributions to VMAT. And you'll see a number of things again. So these are all the views and the dose distribution superimposed on CT images. And if you look closely, you can see that actually the 10% isodose lines, again, we want this to be as tight to the tumor as possible, because that means that we are not irradiating healthy tissues, is actually tighter around the tumor in our kilovoltage arc dose distributions. And it's shown over here, and it's shown in the other view as well. So we were very pleased with these results. And this is done with treatment planning optimization, but still on a spherical target. Unfortunately, targets are not very spherical. We also had to look at the treatment time. Remember, we don't want the patient to be on the table for typically more than 2 hours. There are treatments that take about 2 hours, like for external beam radiation therapy. But of course, the shorter the treatment, the better, the more comfortable for the patient. And the other thing you don't have to worry about is, for example, patient motion. So this treatment time for the entire dose, which you would never be delivering in a single fraction, was 28.3 minutes, or if you were delivering it in a fraction, is 2.8 minutes, which is actually a very typical time for patients to be on the treatment table for radiation therapy. Now, we quickly realized that, okay, it's nice to be able to treat a spherical tumor. Let's make things even more complicated. And let's look at real targets. Unfortunately, they're never spherical. They can resemble a sphere, but they're never spherical. So since our collimator was designed to deliver spherical doses, we actually had to use a technique that's called sphere packing. That's a technique that's used in, for example, the CyberKnife, which is shown over here, or in Gamma Knife. So it's not a new technique. It's been used, so basically looking at how many spheres we can create an overlap with the target, and those are as many treatments or isocenters as we will need, as many arcs. So in this case, this was a patient that we treated with 3 isocenters or 3 spheres. We also moved from the transmission target that we started with, because there was a real source that existed, and we moved on to a reflection target. So in a reflection target, the electron beam hits an anode that's at an angle and creates X-rays at typically 90 degrees. So this is the side view of our reflection target, and this is the front view of the reflection target. And again, this is the collimator that we have been optimizing to deliver dose to the target, which is the planning target volume, or PTV, as shown over here. So I'm going to be showing you 2 lung patient cases. And again, lung patient cases are important because lung cancer is the leading cause of death among men with cancer. And here are again the kilovoltage arc dose distributions, and Saber, also called VMAT dose distributions. And you can see that these 2 dose distributions are very different, as they should be. If you look at the dose volume histogram, so for this top one is the dose volume histogram for the target. So you can see that our target is with kilovoltage arc therapy here is a little underdosed, but still clinically acceptable. And if you look at the dose volume histograms of the organs at risk, the one thing that we can note here is that the dose to ribs is higher in our kilovoltage arc therapy plan than it is in the megavoltage dose distribution, because kilovoltage beams really like to interact with high atomic number materials, such as bones. So this is something that probably would not break the ribs, but if you cure cancer and get a broken rib, that's probably still worth it. One interesting thing that we noticed here is that, for example, the dose to the heart that you can see over here and over here was actually lower, and you can actually clearly see it in this dose distribution in this view, was actually lower in our kilovoltage arc therapy plan, which was a good finding for us for sure. So we looked at different lung patients, number 2, and you see very similar results, except this patient had a tumor really close to the rib cage, which means that the dose to the ribs was even higher, and this would definitely, at least we think, would break the ribs. So you see that the rib dose is much higher, and since the tumor was also a little bigger, then the dose to the heart was pretty much the same for both of these treatments. So we basically, from this study, we concluded that these dose distributions for lung patients and breast patients are reasonable and could be used to actually treat patients. So this was super exciting. Of course, we looked at other cases, for example, for prostate, but prostate, is really tissue, right? Lung, we took advantage of the fact that in the lungs you have a lot of air. The density of the tissue is much lower, so this is much more easier for the kilovoltage beam to reach the tumor. For prostate cancer, this technique is just not going to work unless we really increase the beam energy. But again, that sort of defeats the purpose of the project. And I forgot to mention the treatment times were about 1 hour for both of these 2 patients. So it was, very reasonable, and it basically satisfied all the constraints for treatment planning. So this would be a treatment that would be feasible to perform. So before Dylan Breitkreutz left the lab, he also ran some proof of concept experiments because he had been running lots of Monte Carlo simulations. And of course, as I mentioned a few times in the past here, in Canada, we like to do things in a very cost-effective way. So instead of having a full, solid collimator, we just put together 2 blocks of brass that were maybe, I think, 1 centimeter thick, and we connected them 6 centimeters apart and used this as the collimator X-ray entry side. This was the exit side, and we just positioned the collimator in front of our X-ray tube on a block of wood, which wasn't very stable, but we have in our lab a rotation state, so instead of rotating the source, we were rotating the phantom. In this case, it was a 6 by 6 by 6 centimeter plastic phantom, and it had GAF chromic films in between, 3 GAF chromic films to measure the dose. We used a 160 kVp beam, 13 MA, and a 5-minute long irradiation. And then we irradiated a different phantom. So first, we wanted to make sure that we actually can model this with Monte Carlo. So we modeled our X-ray tube, and you see that the dose, the absolute dose in gray, agreed really, really well as a function of depth with film measurements. And again, films are just sheets of, you can think of it as a photographic film. It's slightly different. It polymerizes under radiation, changes color, and we measure the color difference. And this is how we measure dose. So these are the experimental results from the solid water phantom. And you see these were pieces of film placed at different heights in the phantom. So this one was at the center, this one was at the bottom, and this one was at the top. And we were again able to get a really good agreement between the measured dose that's shown in red, with the error bars, and with Monte Carlo simulations. So the dose rate was about 2 gray per minute, which is of course quite high. But it was a very small phantom, right? It doesn't mimic a patient at all. We actually cannot quite mimic a patient at all. But we could do a little better. We put a Tyvar phantom, which we actually don't know what the material quite is, on the rotation stations as well. It was 20 centimeters in diameter. And because it was larger, we were able to achieve a high target-to-skin ratio. Remember, we wanted only 5, but in this case, we were able to achieve a target-to-skin ratio of 17. But of course, this is a larger object, so the dose rate decreased to 0.36 gray per minute. And note that the target-to-skin ratio for the smaller phantom was a little lower. But again, this didn't really mimic the right geometry. So there was some experimental validations over here with a very simplified setup. But I'm going to go back to our company that we started collaborating with. And they actually managed to build the first KVAT prototype. And this is how it looks like. Of course, companies can always create much nicer drawings than we can in our lab. So this would be the patient, this would be the X-ray source. It was actually meant to move in and out to change the source to surface or source to isocenter distance as well. This is how the prototype looked like, or looks like. I think it was disassembled, so it looked like. And this is the design of the target. So again, it's a reflection target. This is the electron beam source. It's hitting the anode here for treatment. So this is the therapy X-ray path. And they also envisioned, actually, and ran some experimental validation of this beam to have another focal spot for imaging, a much smaller focal spot. So there would be an imaging collimator and an imaging X-ray path. So basically, at the same time, we could be doing imaging and radiation therapy with the same source. So this is the collimator. Remember, our collimator has a number of holes. They basically changed up the design a little bit, maybe just for manufacturing purposes, and instead of cylindrical holes or divergent cylinders, they now had rectangular holes, but the principle was exactly the same. And this is what happens. This is actually a nice photograph of the GAF chromic film that they used. And this is what happened when they put a number of films just in front of the collimators. And you can see all these little beamlets, diverging and converging at the same time. This is just a simulation or schematics of the focal spot and its measurement on a film. And they have done a number of validations. So they basically positioned a phantom around the gantry. They could rotate the gantry, and they could deliver 360-degree delivery around the phantom. And you see the dose distribution is superimposed, and with a little bit of squinting, you can see that the 20% isodose line is on the skin and 100% isodose line is in the center. So even in this case, but again, for a smaller phantom, they were able to achieve this 5-to-1 target-to-skin ratio. So this was a lot of headache to make this happen. A lot of money went into this apparently as well, which thankfully I didn't have to pay for. So this prototype was abandoned, and then we are now thinking about a second prototype of this machine, and we just basically want to simplify everything. This electron scanning beam was a great idea, and the company actually had a lot of expertise in that. They actually developed the electron beam CT, if anybody's familiar with that, but it just turned out to be such a headache that we basically abandoned that. So instead of having an electron scanning beam, we are basically just going to use a simple X-ray tube, off-the-shelf X-ray tube, at this point at least. Instead of having this complicated collimator that would have to be replaced for a different target size, now we're going to have an iris collimator. So it's basically just a circular collimator that you can change its size on the go. And instead of a gantry, we'll have a C-arm, at least in the first iteration. So this is sort of the idea, a simple X-ray tube, and we'll just be able to rotate the X-ray tube and rotate the X-ray tube around as well. So rotate along 2 axes. This would be mounted on a C-arm, as shown over here, and as a result, we'll be able to do imaging at the same time. So these are some dose calculations that my student, another student, Jericho O'Connell, ran. Is actually in a similar patient that we have already used in the previous study with the previous design. These are Monte Carlo simulation in TOPAZ. The previous ones were run in XNRC. And you can see that, again, the kilovoltage, now called differently, kilovoltage image-guided radiation therapy, dose distribution looks really, really nice again. And for example, if you're looking at the dose to the heart over here, it's much lower in our kilovoltage arc radiation therapy, and that's shown in the other views as well, in the coronal view, for example, as well. So I don't have DVHs for this patient, but the dose distribution looked very nice, so we are quite excited about this. Now, for our second kilovoltage arc therapy design, we are thinking actually about building this in my lab, because this is seems to be like a simple device. So we are hoping to be able to build the machine and actually start with treatments of dog patients. So we have a collaborator in the veterinary hospital, in the veterinary cancer clinic, and they are telling us that there's so many pet owners that cannot afford treatments for their patients, that they're like, oh, that would be great, we'll be able to help bring you dogs for treatments, and we are okay, you don't have to pay us, we can just show up with the dog. So we are super excited. We are looking at some cancer patients for nasal cancer, so these are actually examples. I just took this from a paper, which I should reference over here, but this is the type of cancer that we are looking at. So we have received some of the CT data. So this is just a similar case of cancer, a nasal cancer, for a case that we have tried treatment planning on. And just had to do some 3D volume renderings because it looks really cool. And of course, you can see the anesthesia tube over here. You can look at the tongue there as well. And Jericho ran some dose calculations on this case. So both of them should be a GIFs images. And you can see the CT images on the left-hand side, and you can see the dose distributions on the right-hand side. And this is just the two views of the dose distribution. This is actually quite a challenging case. Remember, I said that bone is really difficult for our treatment planning, and this is showing up to be the case for this particular dog patient as well. But we were able to basically encompass the tumor with a 50% isodose line. We still have to do a more thorough comparison with the plant that this dog was actually treated with, but this is looking very promising. And I am extremely excited about being able to treat dog patients in the Department of Physics and Astronomy at the University of Victoria. And some people already know about this, and not everybody is freaking out quite yet. But this basically would be our first step to be able to eventually treat patients. And by the way, Michael Weil, who is the radiation oncology collaborator, has treated dog patients in the past. And he is a huge dog lover and has had like 11 dogs at one point. So the good news is that we actually have some of the equipment because we like to run things cost effectively. We are getting both of them secondhand. So somebody is just donating equipment to us, which is great. So we're going to be getting a C-arm. This is, of course, a new C-arm. So it's probably not going to look like this, but it's already ready to be shipped in Chicago. And we're going to get a refurbished X-ray tubes as well. So we are actually just got a new room at the University of Victoria, of course, in the basement. So this is sort of the setup. This is going to be the control room, the treatment, C-arm, possibly a robotic arm, which would be even cooler, but we don't have that at this point because we actually have to buy a new one. And what I'm thinking here is basically just going to be like putting Lego blocks together. And hopefully this is going to be pretty straightforward to mount a new X-ray tube on the system, use a detector that we have or we can add to be able to do imaging and radiation therapy on dog patients. So what are the conclusions of this work? We have developed or showed the proof of principle of kilovoltage therapy that can deliver doses to lung patients as well as conformal doses to lung patients as well as breast cancer patients. The treatment times are long, but still feasible. The dose to bone might be a little bit of a critical issue, but this seems to be feasible. We have built, or a company, our collaborator has built the first prototype and shown that this might be, again, feasible, but it was just a little too challenging. So we perhaps reverted to a simpler design that we will be building at the University of Victoria. I just put this dog here who will be coming to the Department of Physics and Astronomy for treatment, hopefully. And we're pleased to say that this $5 million machine could now possibly cost only $200,000. And hopefully everything will be packaged in a single equipment, and everything will be done in a single session, like the treatment planning and imaging and everything. And with this, I would like to acknowledge my collaborators who worked on this, sources of funding, and in general, my group at the University of Victoria. And I would like to thank you for your attention.
Thanks, Magdalena, for your talk. So we have some questions.
For those cases in which you will be able to apply the treatment, it will be as good as the mega electron volt, the linear, or good enough?
So this is something that I have been struggling with. So it'll be good enough. It will not. Basically based on physics, it will never be as good as megavoltage beams. But we have been looking at RTOG protocols, basically protocols that tell you, how much dose can be delivered to these organs at risk and for that much dose of the target. And the treatments satisfied all these protocols for breast and lung cancer. For prostate, that's out of the question. Now, it's a really interesting question because when I'm talking to people in Africa, it's like, okay, we can have this treatment for you, but they don't want treatment that's not as good as megavoltage beams. So for me, I think it's a little bit of a psychological, philosophical question to be able to sell this to them, sell the idea to them. It's like, okay, you can either have nothing or you can have something that's still good enough. But I think there's maybe a little bit of I don't know, misunderstanding about what we can provide and what they want. Maybe not misunderstanding rather than mismatch. But it depends also, I'm sure, who you are talking to. I'm sure some physicians will be fine with getting some treatments, but often what I hear is that like, no, we want these megavoltage dose distributions. That's right. That's right, yes. So in this case, for example, if in megavoltage treatments, the patient moves or the target moves, nobody knows, right? For us, we should be, and I forgot to include some images, I should have done that. If you can image at the same time, or as frequently as you can, this should be a huge benefit for sure, especially for lung cancer. Yeah. So maybe we need to, sell it in a little better way. But in general, I think when people see kilovoltage, oh, that cannot work. Okay, maybe it works okay, but it doesn't work as well as megavoltage. No, it will never work as well. So one thing that I forgot to mention also, that the kilovoltage beams are good for radiosensitization with, for example, gold nanoparticles. So if you put a high atomic number element in the tumor in one way or another, and of course this is already an issue, these kilovoltage beams will preferentially be interacting with these high atomic number elements. So the dose enhancement can be a factor of 2 easily, actually, for our beams. And so then you can be getting twice as high dose in the tumor, and no much lower doses relatively in the soft tissue. The question there is, how do you deliver these nanoparticles, right? And how can you target them? And can you do this in low and middle income countries? That's a different question. But there is some potential for the kilovoltage beam to be as good as megavoltage, but we are not there yet for sure.
Other questions?
I think I've missed something. Are you doing the selling?
Oh, no, I'm not doing. I'm
Okay.
just selling in, figurative speech. I'm not doing any selling. Okay. If I was doing selling, I would be telling people don't buy any of the stuff that I make because it has these, and these limitations. But the goal is definitely to, build a machine that we can sell, that people can benefit from. I don't even want to talk about selling because Michael's definitely not like that, right? He wants to help patients. But if you, want to be able to manufacture these devices, then you have to sell them, or you have to make money somewhere. He's talking about venture capitalists for funding, and some of them are willing to fund. That's how we get the first prototype to get built. But yeah, it's challenging. And actually, the other thing that I wanted to mention is that this is a market that basically the big companies are not interested in, because they want to be, building stuff for high-income countries, because that's where the money is. And every time, I don't do any talking to anybody really, but Michael does the talking to people, and like Varian and Electa, and I don't know, for treatment planning research, they're like, no, we don't see that this would bring us money. So this has been quite challenging for us, but I feel like the atmosphere is changing now, that people are more willing to be doing research for the benefit of low and middle income countries to decrease the cost of radiation therapy. It's very often done on the software side. For example, treatment planning or contouring takes time, right? It's actually a physician that has to go and contour every single organ. But you can use artificial intelligence or machine learning to be able to do this at least semi-automatically. That's where most of the effort is being put for low and middle income countries. On the hardware side, not so much. But it's been difficult to raise money for this, from what I hear. But for me, if we can, build this machine at UVic and just help a single dog patient, I would be over the moon for sure. But hopefully we could treat more.
Okay, more questions? Oh, okay, we thanks again, Magdalena, for your talk.
Thank you.